Good afternoon, everyone. This is Jason Harris with the National Health Council. Just wanted to welcome you to the second part of our webinar series on patient engagement in value assessment. I think just want to give folks who are scheduled to call in another 30 seconds. So we will get started at 3:01 Eastern, and so just hold on right now, and we'll get started very shortly. All right, so once again, this is Jason Harris with the National Health Council. Really appreciate everyone making the time to join our webinar today. We have a great lineup for you and a good presentation. So if we could just hit the next slide. As you'll see, this is part 2 of our webinar series, An Introduction to Health Economics and Value Assessment. Many of you probably were on our first series in the webinar, which was an overview of value frameworks, where we discussed, really just reviewed the current healthcare environment and the role of value and how that plays into what we discussed on those value frameworks and assessments, a little bit about the basics on what they exactly are. We discussed some of the key U.S. value framework and assessment organizations in the U.S., and then a couple of tips and hints for patients and patient advocates to look out for. And so really, if you hadn't got a chance to listen to that, we will have that recording available likely sometime in early November. And so all of these webinars will be up on the web shortly. So just wanted to give that heads up in case you weren't able to see it. So part 2 today, what do we want to talk about? We're going to look at describing the environment that's driving value assessment. We're going to give an overview of a number of key terms and concepts that we want you to know. It'll be very high level. We don't want everyone to, think you have to dive into the details, but we certainly want to mention those key terms and concepts that you'll see as you start to dive into the value world and the value assessment world. We'll give you a couple examples on exactly what we mean related to some terms in cost effectiveness, and then we'll also have a guest speaker who has a lot of experience in the value assessment world, and Leah Howard from the National Psoriasis Foundation will share her experiences when she had to start getting into value assessment. So with that, I want to introduce our main speaker for the day, Dr. Joey Mattingly. Joey is an assistant professor in the Department of Pharmacy Practice and Science at the University of Maryland School of Pharmacy. He's also the Director of Operations for the Patients Program at the University of Maryland. His primary research interests include pharmacoeconomics, patient engagement, and social media. And so with that, I am going to turn it over to Joey right now. Joey, all you.
All right, thanks, Jason. Thanks for that introduction. So if you want to save time, let's just get into it. I'm sure many of you all have seen a slide like this before. The feeling of national health expenditures in the United States are increasing. And I think what's important to point out about the increase in healthcare expenditures is also that as a percentage of the budget, it's increasing, not just like the overall gross amount, but growing at a faster rate than other goods and services that we may compare to. And so this really causes for an alarm for those who are trying to manage budgets. So first, why are healthcare costs increasing? Well, the first half of that story is good news, right? People are living longer. When we have new medicines, new advances in healthcare, we get longer life and longer life expectancy. With that, we have people who are, when we talk about the baby boomer generation, as they age and move into retirement age, this aging population is going to be utilizing healthcare. Also, issues like chronic disease. And again, I guess another piece of the story, though, and again, because the aging population is only one part of it, many of the new advancements in medicine come with a very high price tag. And so we're entering into a new era of more personalized medicine. And so previously drugs were marketed for larger numbers of patients. So the price per patient was considered high if it was $100 or $200. Well, now we're seeing medicines coming out at $1,000, $2,000 per person per pill. Maybe the overall treatment is $100,000 or $300,000. Now we're seeing these numbers that just look vastly different. So, whatever your political beliefs are around price gouging or whatever your thoughts are in terms of or what your views are there, I think the one thing is clear is that Americans are demanding more of an assessment of the value that we receive for the dollars we spend. And so back to kind of, when we look at our overall expenditure, we do have a combination of the price of what we're paying and the quantity of what we're buying. You multiply those two together, you get your overall expenditure. And so as more people are using healthcare and healthcare prices are going up, we have kind of a double whammy of expenditure rising at a pretty fast rate. And with this, as prices rise and our budgets rise, insurers, are often referred to as the payer, are feeling an increased pressure to reduce the cost of healthcare in order to make premiums more affordable. And so with that, there are several cost containment strategies that have been used by insurers. And so some of them may be limiting the benefits where only the insurer only covers a set of drugs on a formulary. Maybe they restrict access. There may also be utilization management tools. So you may be familiar with prior authorization or pre-approval step therapy strategies where we want the patient to fail a therapy first before we give them maybe the newer, more expensive medication. So we're seeing these strategies employed quite often across multiple payers, and I think that's probably what most people are experiencing. When we employ these strategies or we use these strategies to contain costs, there's some unintended consequences that come along with that. One of the several downsides, if you will, is that we can focus on the quality, or instead of, or it's a cost focus instead of a quality focus, I should say. So, as we require patients to fail first. Well, obviously that's from a patient perspective, that's not going to, who wants to take the worst, the drug that maybe has a higher percentage chance that it's not going to work for them? Who wants to start with that one, or is that something that from a satisfaction standpoint you want to see? Does it restrict access? Does it harm access? And when if a patient out-of-pocket cost increases as well too. So again, there are we see these cost containment strategies, and then we also see sort of effects from that are intended and some are unintended. So I think one of the things that we and why we're here today to discuss this is as healthcare costs rise, we want to know, okay, we're spending more. Well, what type of value are we getting? And so can we get better quality and value from the results in higher healthcare expenditures? And a lot of times you may even hear a phrase like, do we get good value for money spent? And so what sort of tools are used to answer these questions? And when we talk about value, who's capturing that value? So value to whom? We may see a good value from the insurer standpoint managing a population, but do we see that same value from the patient standpoint? And does the patient feel that as well, or are we talking about a government? So there's different ways you can kind of ask who's gaining the value. And so I think one of the things that we hope that this module and other webinars that we do, we hope that it helps educate and help look behind the curtain. And again, we kind of use a little cartoon of, sometimes you always hear about like wondering how the sausage is made. We see these costs and this expenditures that we're putting in, these resources that we're putting in to determine this, and we come out with outcomes like cure, side effects, nausea, fatigue, and trying to come up with a value calculation through a cost effectiveness study. Like, what does that mean, and how do patients or patient advocacy groups learn about what's going on behind the curtain. And so a health economist uses tools to help answer questions to value. Results may be depending on many factors and can sometimes be quite complex. And so my hope is that we can reduce some of that complexity so that more people can understand it and understand the consequences, benefits and the consequences of health economics. Usually health economics or these cost-effectiveness studies, they're not really created by, for, or with patients. And that's something I've really applauded NHC for working with us here at the University of Maryland and other universities to try to bring patients into the mix to be more involved. And so today I'm going to cover a handful of definitions. So again, don't try to memorize all these just yet, but we'll walk through each one of these terms, and some of you may already be familiar with them, but hopefully some of the stuff, or there may be some stuff that's new for you. But we'll want to talk about these terms in the context of cost effectiveness. So the first term I want to talk about is efficacy. When we hear the term efficacy, this is referring to treatment's capacity to produce an effect. This is essentially, and put it bluntly, it's clinical trials are designed under these perfect conditions, and they're designed to test whether a new medicine can work. And I definitely don't want to disparage a clinical trial, because I personally believe clinical trials have helped us move into have really advanced our knowledge around whether medicines work and get us away from drugs that aren't truly efficacious or aren't really making a difference. And so we use randomized controlled trials in these perfect settings, and we see, does drug A beat placebo in this perfect group of patients? And this allows us, the FDA, to approve drugs. We say, okay, there's efficacy and safety that we get from these clinical trials, and we're going to put this on the market. But we know that in the real world, you're not necessarily set up the same way a clinical trial is. We don't have all the inclusion and exclusion criteria. When a drug is approved, it goes into the market and it goes to people who would likely not have been approved for that clinical trial. And so for that, we need effectiveness studies. So effectiveness is these are the type of studies that are intended to use in these real-world settings, and sort of helps us understand how drugs will improve health outside of that perfect environment. And we want these studies can maybe help us with formulary decisions, maybe help us see, how does this affect a certain minority that may not have been recruited into that trial, or a certain group of patients with a comorbidity, another disease. Maybe you were, there's a brand new drug for cholesterol, and so the drug company didn't want to recruit patients who had heart failure, for example. I'm making this up as we go along, but say they excluded all those heart failure patients for the clinical trial. Well, in the real world, we know that maybe some heart failure patients might be on these drugs, so we can use effectiveness studies to see, do these drugs have the same effect or similar effects in these populations. So a recap. We think of efficacy as a very controlled, tightly controlled setting, and remember that's why it's designed. It's meant to try to cloud out all or knock out all the noise and focus on, is A better than B or is A better than placebo? And it's important for FDA approval. Whereas effectiveness, so when you hear the term effectiveness used in our context, we're talking about a real-world setting, and this is important for payers. So let's shift gears now. We've talked a little bit about efficacy and effectiveness, and let's talk about cost. So the first type of cost I like to discuss is the direct cost. This is essentially all the resources that are consumed in a healthcare setting. So this might be your drug cost, maybe the cost for the procedures, the physician time in the process. This may also include a facility overhead fee or overhead charge. A lot of times when you really break down that hospital bill, you start seeing a lot of the other costs that are directly tied to that hospital stay. And then maybe a lab test and so on. And another thing that also impacts direct costs that we like to look at in economics is not just your cost today, but your direct cost of care tomorrow and in the future. So it's important that we include current and future costs that are directly tied to care. Now, this is different than, say, indirect cost. And indirect cost is referring more to like that loss of productivity of goods and services. And in this, you see the image of a iceberg, and then I think it's probably the easiest way to picture it is that we see our direct costs on the surface, but all these indirect costs that are kind of hidden downstream or hidden that we don't always see or don't always take a look at that we try to capture in these economic studies. So this might include something like misproduction or lost productivity due to disease. Maybe you're unable to go to work, or instead of working full time, you got to take a part-time job because you can't stand for 8 hours or whatever that may be. So there are components of the disease that are maybe not directly tied to the treatment of the disease, but we know there's a cost from an economic sense. What about misconsumption? What about not being able to purchase other goods and services? And what about caregiver burden? How often do we think about a disease and just how it impacts the patient? But we all know in real life that many diseases impact our family, our parents, are especially those that are taking care of us, our husband, wife, son or daughter, who are now they're missing work as well to come help you with doctor's visits and coming in and out of the hospital. So there's actually still debate whether or not these type of costs should be included or how they could be included, because as you can imagine, these indirect costs can grow rather quickly, and from a payer standpoint, does the payer fully does it help them with their budget if they know that okay, so we've approved a treatment that's going to reduce indirect costs, but it's not going to change direct costs to the insurer? Is that something that that they want to consider? So in our we have put together a more advanced set of modules that actually dive into the quality adjusted life year in a much more specific format. And for today's topic, I mean, I could spend this whole call talking about the quality. So you may have heard of this acronym, Quality Adjusted Life Year, and this is an attempt to to take, I guess, essentially to discount what's happening with quality of life, or to try to I don't want to use the word instead of focusing purely on whether or not a treatment adds life, but whether or not taking that treatment improves the quality of life while taking it. And at first you're thinking, well, hold on, I don't want you discounting, years based on quality of life. I want to live longer. I think it's important to use an example like, think of a pain medication. If we didn't use quality of life if we didn't consider quality of life a drug that only reduces pain but doesn't extend life expectancy, we would say, well, that isn't worth anything. So I like at least that we're attempting to adjust for quality of life, but there are several limitations to the quality, and we don't have enough time to get into all those limitations here. I just want to make sure for the folks on the call that I've given you a little bit about the definition of a quality. Essentially, it's a score that'll range between 0 and 1, and so 0 would reflect being dead, and 1 being perfect health. And so as I get older, I know I'm definitely moving further away from that 1 of perfect health. But that's in a nutshell. It's an adjustment that's made off of. So instead of adding, if I had a new treatment that added 10 years of life, but the additional years, maybe I have some quality of life issue in those 10 years due to the treatment, maybe we would discount those years and it wouldn't be a full 10. You'd multiply it by that adjustment. And again, it's not universally accepted, and it is controversial, so we'll just leave that here for now. So I do want to talk about cost effectiveness as a tool, and really talk about this incremental cost effectiveness ratio that many of you have, or if you have read anything around cost effectiveness, maybe you've heard of this ratio. And one thing to point out, if you're more familiar with some of the groups that are doing value assessment, ICER is also the name of a nonprofit organization called the Institute for Clinical and Economic Review. So cleverly, they named it ICER, given that ICER is also the main acronym, so it's hard to forget. But for today's topic, we're talking about the incremental cost effectiveness ratio. So that's when I say ICER, that I'm talking about this ratio. And really all it is a difference in cost. So you kind of see in the picture here on the right, we got cost of drug A minus cost of drug B. In the denominator, we have the effects of drug A minus the effects of drug B. And the reason why I mentioned the quality in the previous slide is that in most cost effectiveness studies, the effect number comes from that quality adjusted life year. And you could do it just by pure life years alone if you're just looking at mortality. You could also do it like the effect could be maybe injuries avoided or asthma attacks, severe asthma attacks avoided or something. You could make the effects something different, but the most common one that you'll see is this cost per quality, and that's why I think it's important that those who are trying to learn about what's happening to at least know what this quality thing is. And so, how do you decide on which cost or which effects to use? So this is where I hope by you guys kind of you all learning cost effectiveness that you'll start asking questions like, well, where'd you get the cost? Where'd you get the effects? Because it may be impacted by things like perspective. Whose point of view was the cost analysis conducted? Who is accruing the cost and the benefit from the treatment? When we talk about cost, are we only focused on direct cost? Are we including any sort of indirect cost? Is it the cost to the patient? Is it the cost to the payer? Is it the cost to a government? Is it, what does it mean? And so we're going to run through an example, but I just want to kind of, tee you up to thinking about like how these different perspectives might impact what we choose. And so again, like when we think of a payer perspective, so from an insurance company or a government like Medicaid or Medicare that's paying for the care, they typically want to focus on the direct medical cost. So this might be the cost of treatment, and again, the cost of the physician, the cost of the inpatient, outpatient admission, or inpatient admission, and it may also include today's cost and tomorrow's cost and future cost and whatnot. But from a society perspective, we should include both direct and indirect costs. The societal perspective should at least account for things like burden to caregivers or loss and gains of productivity, because we know from society that we are gaining something from that if we use a treatment that actually gets people back to work and gets them out of the hospital and where they can also take care of their kids, and so we know that there's a benefit there too. So understanding what these perspective differences are, and what one of the big recommendations now is for folks like me that are doing cost effectiveness studies is that we at least attempt to account for both of these in our analyses. But we'll see how over the next few years how successful it is. Because I will say, as someone that tries to do this research, that society perspective is pretty tough. It's tough to capture all the things that the downstream effects that could be happening when we get someone treated. So with the last couple of minutes for my part before we turn it over, let's walk through an example just to kind of give you an idea of how an ICER might be calculated and or what an ICER would, so that way you can kind of see what an ICER looks like, but then how impactful certain assumptions can be on that. So if we had the cost of a new treatment versus a standard treatment, remember we're calculating our numerator, and we'll divide that by the total qualities or the effects of maybe this quality adjusted life years with the new treatment minus the total qualities that we estimate with the standard treatment. And let's say that we're using a drug. Now, I pulled some data from one study, so don't quote this study as the end-all, be-all answer for this one area of drugs. But one of the cases was PCSK9s. This is a new set of drugs that's used for high cholesterol. One of the studies that we found showed that PCSK9s as the new treatment, the total cost in their treatment group was around $380,000. And that when they compared it to the total cost in the treatment group that just got statins alone, their total costs were $220,000. So you can see a cost difference of about $158,000. And they also noticed that over that model and the way that they did the economic model, that the patients getting the PCSK9s would experience about 1.2 qualities more, greater than the control group. So you just do a basic, and this is like a base case average, average cost minus average effects, or average cost minus average, or the difference in cost minus divided by the difference in effects. And we have this ratio that comes out to be $141,000 and $699 divided per quality. So you'll hear that like $140,000 per quality. Now this is just one number. So how do we interpret that? What does that even mean? During a study like this, we don't always have every single perfect piece of information, and economists typically have to fill in some of the gaps with assumptions. And so we do additional analyses called sensitivity analyses where we can play with those assumptions and say, okay, let me go back real quick. Let's say when I did my $380,000 minus my $220,000, what if when I calculated my PCSK9 cost, what if I used the total, like the list price of the drug? Like the list price, guys. This is that wholesale acquisition cost. This is like going to a car lot and paying sticker price on the window, right? This is that high number. What if that's the assumption that I used? But I know that in real life or real practice that these insurance companies or the government may negotiate a discount. So now what if I wanted to say, what if I played with that assumption and I said, actually I believe that there will be a significant rebate for this drug because it's a brand new drug and the drug company is going to try to get on the formulary, and so they're going to offer a rebate or discount. Let me adjust this by some amount, and it's great if you have the data, but you don't always have that data, so maybe you have some assumptions that you can make. And again, not to plug any papers, we'll have some papers coming out, hopefully giving some recommendations about how to do this. But say we reduced, we estimated that the total cost in this PCSK9 group actually would be less than $380,000. Maybe it would be closer to $325,000. Well, we find out that when we start doing our ICER calculation, that now our ICER value drops from $140,000 to about $90,000. And you say, well, okay, why does that matter? Depending on the group, there are different sort of thresholds or levels that maybe the payer or someone's trying to make a decision, like, okay, is there a threshold that that matters for this quality when we compare it? So, just to give you an example of how as the economist is building this model, it's really important to challenge and to say, okay, how do you come up with these inputs, and then when you change the inputs, what happens? What happens to the model? How big of a difference does it make? Because sometimes you can change the inputs all day long and the cost per quality doesn't change a whole lot. And that lets you know that the model's, it's going to be pretty, what they'll say, pretty robust or pretty standard, that may be a good estimation for the cost per quality. So with that, and again, I think hopefully if you have questions, you will be typing those in or send those in. We can hopefully have some time for Q&A at the end. But with that, I want to turn it back over to Jason so he can introduce our next speaker.
Yes, and thank you, Joey. Great presentation. Definitely appreciate all the work you put into it there. And so again, just to reiterate, if anyone has any questions, I know we've gotten a couple which we'll get to during the Q&A portion. Feel free to type those into the chat. But right now I want to introduce Leah Howard from the National Psoriasis Foundation, and newly promoted to the first ever Chief Operating Officer of NPF. In her new role, she'll provide strategic direction, vision, and leadership to all the Foundation's mission-related functions except research, so that includes government relations, advocacy, marketing and communications, education and outreach, and a number of other things that she can certainly tell you about. And just one thing to add is Leah has certainly had a plethora of experience in value assessment, which she's going to get to, but really has been someone who we've leaned on to hear about her experiences, as well as she's been able to share her experiences with other groups to better theirs. So with that said, Leah, I will take you off mute, so give me 1 second, and you should be good.
Great. Thanks, Jason. I appreciate the opportunity to join everybody today and to share a few thoughts about the experience that the National Psoriasis Foundation had participating in a value assessment by ICER, the group Joey referenced a few minutes ago last year, and kind of the thinking that we did around a lot of the topics that have been covered today. So I'll just offer a few kind of high-level thoughts and then would be happy to answer questions anyone has during the Q&A. So in late 2015, ICER, which is one of several value framework modelers, as you may know, announced their list of drugs that they were going to be reviewing in 2016. And among those on the list were 2 psoriatic disease therapies that were expected to be approved by the FDA last year. And so the NPF reached out and sought to begin a relationship with ICER so that we could be engaged in their assessment process as it moved ahead. And because this is not the type of work that's typical for a patient advocacy organization, there was obviously a lot that we had to do as an organization to get up to speed in order to participate both as staff from the NPF, as well as to engage our patient community and our provider community in this assessment. And so really over the course of about 6 months, the first half of 2016, we sought to educate ourselves about what the assessment process looked like, the various opportunities that we had as an organization to contribute to it, and what data and information we could bring to the process ultimately to most benefit our patient community. And really that was what was driving our entire interaction with ICER through the assessment. One of the 2 main goals of our mission is to dramatically improve health outcomes for our community. And we knew that in order for us to do that, we needed to help ICER to understand just how impactful the therapies are in our space and how much value they bring to patients. And so a lot of our early work was trying to understand from ICER's perspective kind of what they saw as those contributions to these equations that Joey just walked through, and kind of from a patient perspective, what patients considered the critical outcomes as well as the costs, both for the therapies as well as for not treating with any of the therapies in our space. And so that was really several months of work trying to understand what information we had, kind of how it fit into these various buckets you've heard about today, and then educating both patients as well as the providers and researchers that worked with us about these kind of key data points and how they could contribute to the conversation. So really, because these are not typical conversational terms that patients are familiar with in particular, a lot of our early interaction with our patient community as we talked to them about engaging with ICER wasn't even so much about the ICER process, but really about kind of what was going on here, who ICER was and what this value framework assessment consisted of. And to do that, we had to really break down for them kind of each of these terms and these concepts so that they understood how their stories and their experiences could be fit into overall the assessment process, as well as the actual assessment calculations of the therapy. So from a patient organization standpoint, that's obviously a a lot of time and effort, and certainly pretty time intensive at the outset. But I think what we saw is that the results of that were certainly many, and that ultimately it gave our patient community a greater understanding about what we were doing and how it was serving them and helping to improve their health outcomes. And it enabled us to really have a conversation with individuals living with psoriatic disease kind of throughout the process, because they had an understanding of kind of what the common terms were and the role that their perspective played in terms of fitting into the process. So that was a very quick, high-level overview. I'm happy to answer any questions and kind of talk with you more about how we broke down various elements. The only other thing that I would add is, I think from a patient organization standpoint, what I've seen at the NPF, and certainly talking to colleagues in other organizations, is that I think we all sit on quite a bit of data, and maybe we don't define the data in the same way that a value framework modeler does. But a big part of our engagement in a value framework assessment was really taking stock as an organization of all of the data points that we had with our control, and really trying to look and see how those pieces fit into a value framework assessment. And maybe we didn't title the data the same way a value framework modeler did, but when we started to look through our patient data and the information that our patient community has shared with us, we realized we had a lot of the things that they were going to be thinking about, like the impact of the disease on the patient's ability to work. Joey mentioned the indirect costs of treatments, and from our perspective, we had that information as well as the indirect costs of not treating the disease. And so our ability to bring forward that information and present that to ICER, I think, was a critical part of what made our engagement so successful. And ultimately, what we saw as we worked with them and talked with them was that the information that we were able to bring forward helped them to revise their assessment of the 8 therapies they were looking at in our space. And ultimately, ICER concluded that all 8 of the therapies they reviewed for psoriasis treatments were of good value, to use the term Joey mentioned earlier. So from our perspective, it was certainly a successful engagement and a successful assessment, because they were able to pull in all of those patient perspectives and patient challenges and those direct and indirect costs that we as a patient organization wanted them to be aware of, because they were those things that we heard so much about from our patient community over the years. So I'll pause there, and I'm happy to answer questions.
Thank you, Leah. One question that did come in, and we have a number of groups, I think, on the line that are probably dancing around and playing with whether or not to get involved and things like that. So just for you, Leah, we got one question around sort of how did you decide to move forward in getting involved? Because I know there's a lot of work that you had to do and groundwork for your organization had to do to get going. So someone was just curious about that sort of decision making.
Sure. Yeah, I'm happy to answer that. So I think it's a really, I saw it as kind of a multi-stage process. There's no harm and very little effort that goes into kind of making that initial outreach to the value framework modeler and introducing yourself as an organization and alerting them to some of the resources and data points that you have on hand that they might be interested in. I think that there are certainly points along the way where you realize that, this could be somewhat of a rabbit hole I'm jumping into in terms of the amount of work that might be involved. For example, there's several comment periods during the course of an assessment where you can reflect back on the documents that have been presented to date and share additional information to a value framework modeler. Certainly, each of those comment periods, as they kind of build and grow in terms of the documents and data that you're looking at commenting on, take increasingly more amounts of time. And I think along the way, as an organization, you probably are are best served kind of looking at each of those saying, do we comment? How substantive is our comment? How deep is it? And how much time and energy and resources do we put into gathering information and preparing a response here? From our perspective, we have talked a lot to health insurance companies and pharmacy benefit managers over the years, and one of the things that we've consistently heard from payers is that they don't have a lot of data with regard to psoriatic disease and kind of how they should be covering our patient population. And so they're looking to folks like Value Framework modelers to give them data, give them guidance. And so we felt that if this report was going to come out and actually serve as some sort of a basis for insurance development design for our patient community, we really wanted it to be reflective of the actual experiences of the patient and clinicians that serve our patients. And so for us, that meant kind of diving in head first and really making that commitment, whatever it was. I would say it's a very heavy commitment. It can be a very heavy commitment in terms of staff time. I think the degree to which you bring other elements forward and other costs forward for your organization really depends on kind of how you want to approach the engagement around a value assessment. You certainly can go out and hire an economist and an outside expert that can help you to develop your response, but that's obviously an additional cost and something that might not make sense for your organization. But I think what you'll find is quite often you have a number of resources at your disposal. Certainly, in our case, we had patients that wanted to share their perspectives directly with ICER, and we had a medical board that wanted to offer contributions on the science side. So we were able to pull those experts together and draw from their knowledge in developing our responses and our submissions.
Thanks, Leah. Joey, actually, if you could go back to slide 23. Yeah, right there. It could have been that. Just a question we received. Can you explain how the qualities from the ICER, the 10.51, for example, are determined when the score is from 0 to 1?
Oh, great question. That is a great question. Yeah, so I should have clarified that a quality is an adjustment versus, here, let me say the best way to say it. Let me go back. So the best way to explain it is that, and again, maybe I need to rephrase this, and I'll probably change the slide to adjust, is that the 0 to 1 is the utility score, not necessarily the quality, like the exact quality score. So it's a say we ask 100 people, how we rate, how would they rate their quality of life? Maybe we use a tool. There's different survey tools you could use, and they may rate, and we make a calculation based on the scale that, okay, if I am at perfect health, I'm a 1, and if I were to be in a wheelchair, maybe I rate that as a 0.7, so something less than 1. Then what I do is I multiply the number of years of life for the next 10 years that I'm in a wheelchair by that number 0.7. And so rather than the number being 10 years of life, you would say, okay, taking this additional treatment, instead of being perfect health, which would equal 10 years, it's going to have a reduced quality of life, so it's going to be 0.7 times 10, or 7 years. And so that is a great comment and a very good question, because I think what I didn't explain well is that it's actually a utility score, and then you calculate the number of years of life multiplied by that quality adjustment. So very good catch and a great comment, because like what you'll see is. So and again, I don't remember exactly how they did it in this study, exactly like what the total number of life years added. But say the treatment was really going to add a total of 15 life years, like mortality would extend by 15 years. but based on whatever the estimation and quality adjustment, maybe it was adjusted down to 10.5. And by doing the same to both sides, like they're both adjusted, but so so we don't know necessarily just by the numbers that I gave you whether the 10.5 is greater because, like, what if in both studies the life years were the exact same? Like, what if statin users and PCSK9 users, we estimated that the average mortality would be the same? And so, but we realized that maybe in this study that the quality of life was better for the PCSK9 folks, and so maybe that's the reason why. And I'm just making this up, like it could be either way. So, great question, and I hope I clarified. And Jason, if the user wants to contact me, please feel free to send out my contact information if they'd like to talk more, or if I can be more help be more clear.
Absolutely, will do. I'll just take a moment and give everyone 30 seconds for any other questions for Joey or Leah. Okay, well, not seeing any other questions. Just as a reminder, certainly want you to mark your calendars for the part 3 of this webinar series, the final one, how the patient community can and should be engaged in the value assessment process. It'll be November 6th from 3 to 4 p.m. Eastern, 12 to 1 Pacific, and we certainly hope you'll join that. We'll make sure to get that calendar invite with the webinar information on your calendars, especially if you attended today. And with that, if you have any questions or you want to chat with Joey, just give us a shout. This is Eleanor's information, but you can email myself or Rachel. We'll send out information in a follow-up email. And I also just want to take the time to thank both Leah and Joey for taking the time to join us today and provide their expertise on this certainly very emerging issue that we'll all be dealing with if you haven't shortly. So thank you to everyone, and have a great rest of your day.